a very strong opinion about this, but I might be wrong. Objectives is to understand development in the cone of economy. I think we have fallen away from understanding the relevance of cone of economy as we fuse people, understand the limitations of historical growth standards, and objectify normal alignment through the vertebral pelvic angles. And I think one thing that gets a little conflated when I give this talk with people is that I am discussing biomechanically perfect, I think. In the perfect surgery, Jeff gave a great talk about this in New York. The right surgery for a patient includes patient preference, what they want, what their tolerance for risk is, what the surgeon's capabilities are. And so while the plan might say do an L4 PSO, that might be the wrong case for that patient if their preferences are, I don't want any complications, or I don't want, the surgeon says, I don't want to deal with this blood loss on a Ben Elder case that's going to bleed like crazy because the bone's a bunch of glass. And so the right surgery is not necessarily the biomechanically perfect construct, but if we are going to get to prescribing the right surgery, we need to know what the perfect biomechanical construct is. And then we can add the other things, and then we can have precision medicine. So just quickly, right, we are descendants from apes. They have globally kyphotic spines with very low pelvic incidence. And Rusali has actually discovered, or investigated sort of the development of the human skeleton quite a bit. And as you notice, also the shape of the skull changed. And the shape of the skull changed both for our vestibular ocular reflexes of standing upright and walking, and to change our cranial center of mass. We develop in kyphosis, and these acquired curvatures come with crawling and then with bipedalism. And this was the first way I wrote this slide, is that this cone of economy is a balance of cervical lordosis, thoracic kyphosis, lumbar lordosis, PI, and lower limb alignment. And the goal is to minimize energy expenditure. So prior to degeneration and aging and frailty like comorbid problems, we stand in the most biomechanically favorable position. Now, if you think about it, it's actually a balance of kyphosis or lordosis, right? Lordosis in the cervical spine is not nearly as common as we like to think it is. Then it's some kyphosis over some number of segments, some lordosis over some number of segments with a fixed PI and whatever their lower limb alignment is. I love this paper from JBJS from the French Spine Surgery Society, where they discussed development of the sagittal planes as children matured. And they used three curves for the thoracic kyphosis. I think it's much easier if you think about thoracic kyphosis as an upper TK and a lower TK, and then you think of an upper LL and a lower LL. And what they found was that as you get older as a child, not as a grown, mature adult, but from 8 or 9 to 14 years of age, your PI on average goes up. The scatter plot, right? And this is sort of goes to my comment to Basil earlier. This is average, this is reality. And it's very difficult. You need to be careful with applying averages to populations when they're individuals. But what we do see is that on average, the PI increases. As the PI increases, the pelvic tilt increases. So if the PI and the PT are going up, what happens to the sacral slope? Sacral slope is static. And this is because the femoral heads are growing further away. It's A to P growth of the pelvis with a static sacral position in space. Now we know that pelvic incidence is the sacral pedestal, right? Driving the sagittal curvatures. What do we see happening in the lumbar spine? We see an increase in lumbar lordosis, right? Which is what I think all of you would answer if I said, what happens to LL as PI goes up? LL goes up. But where does it happen? It happens in the upper arc. The upper arc is where you add lordosis as your PI goes up. The lower arc is static. And if you look at the adult papers, the lower arc is static from 8 years to 70 years, right? It's an average of 35-ish, but some people are down at 20 and some people are up at 45. And I think I like this because this sort of jives with the Rusali classification of the ideas of these different curvatures and understanding that lumbar lordosis is not necessarily L1 to S1. And that reading L1 to, I want you to leave this meeting and read L1 to S1 in a paper and say, I don't know what that means anymore, because it doesn't tell you anything about the distribution. So now, if the PI is driving the proximal lumbar lordosis change, where does the thoracic kyphosis change, right? Because there's a slight increase in TK. Geometrically, and this helps plan your cases, whether you're doing a pediatric case or an adult case. Geometrically, you can't argue against this, is that the upper arc of lumbar lordosis is equal to the lower arc of thoracic kyphosis. They are congruent angles. Has to be equal. And I think, you know, in the peds world, now they love saying T10 to L2 is 0. It's not 0, that's flat, that's a line, that's not even a shape. It lacks an arc. And I think that's where they get into some trouble, creating things that are hard for adult surgeons to fix 30 years down the line. So it gets a small increase in TK, but it all comes in the lower arc of thoracic kyphosis. So just remembering, pelvic incidence is the foundation. So initially, right, we wanted to just prescribe lordosis by PI. And this is the regression. Here's some confidence intervals. The regression is about 60% of PI plus 30. But the R squared, which is some measure of model fit, is 0.3. That's quite low. And that means, like, look at this person, 43, could be 25 or could be 45. That's a huge difference. Really, really big difference. Initially, this was sort of one of the first passes. I think this was also a little bit of a reaction to the wild success Dr. Lenke had with the AIS classification system, which actually is completely different goals and fundamentals. This describes patients. Lenke classification tells you what to fuse. But it brought us to the PI minus LL, right? And the importance of PI was recognized, but this is really what hammered it home and really got this idea of PI minus LL mismatch into people's heads. I think it's important to note here that there are no absolute value symbols around PI minus LL. Those came in a subsequent study where now you just wanted to be within 10 degrees. Didn't matter which side you're on, which then gives us a 20-degree range, which I think we would all agree is reasonably inaccurate and certainly not moving us towards a precision medicine approach to spinal deformity surgeries. They also used SVA. SVA is really not a great measure because you can maintain your SVA with very high pelvic tilts. And they use pelvic tilt with these categories, right? Categories that don't account for the fact that PI and PT are related. They don't account for the fact that a PT of 19 and a PT of 21 are going to be termed different, but a PT of 21 and a PT of 30 are the same. That's just illogical. And that's because we make these categories and we cause problems by categorizing the continuous. This set the sort of standard for us. And one of the problems too is then it then went to, it was used for patient-reported outcome measures. And we're all talking about technology coming to get us. This is supposed to say PI minus LL is dead. And I tried multiple times, just like arguing with the AI, saying like minus, and it just got worse and worse and worse. So I need you, because I did just notice it says Immius. But PI minus LL is dead because this is not a precise approach for us. It doesn't tell you about the distribution. And what we know is that PI and total lordosis have a nonlinear relationship. And applying these static categories and linear thought to it is not useful. And then the PI minus LL mismatch, it itself varies with PI in a nonlinear measure. So we need to get away from saying I matched PI minus LL, writing papers where, say, we compared groups that had PI minus LL absolute value of 10 to those that didn't, and we made a bunch of p-values, and this is what we discovered, and this is why you should do this. It's not correct. Pelvic tilt's also dead. 97% of the population has a pelvic tilt of around 25 or less, but look at the distribution. It's really wide. There are people with very low. If this is where you're supposed to be, and I give you a surgery that puts you up here, that's not good. Biomechanically, that is not going to be good. And SVA is also dead. And at the same time as Schwab developing his classification system, Rusoli, who, if you've gone to the SRS meetings, you've heard him get up and speak, and he just says, there is no lordosis. And I remember distinctly in Bologna seeing an MIS deformity session, thinking, wow, that's pretty good. Like, look at that, they have like 30 degrees of lordosis. He got up and said, there's no lordosis. And I sat there and went, what is this guy talking about? Because I didn't understand that 30 is not enough, and that that patient needed 50. And so he used sacral slope first. Sacral slope is not a fixed factor, so I think thinking about it in terms of pelvic incidence is much better, where he described normal spine shapes. First 5, and then classic, Hills loves this, when we make categories where they don't exist, and then we find things that don't match our categories, do we go back to the drawing board? No. We make subcategories. We make 3As and Sanders classifications. I don't even know what a 3B Sanders is. I don't pay attention to it. But it's based upon sacral slope and the shape of the lordosis. Important things from this is he recognized the really random choice of L1 in our measurements. We chose L1 because it doesn't have a rib on it, not because it's always the upper end vertebra of your lordotic arc. And if you have a low PI, it's probably not. If you have a high PI, it's probably not. It's a spectrum. I think when I give this talk and Frank Schwab makes comments, I think he very sort of correctly and astutely points out that this doesn't exist, just like Hills would tell you. It's a continuity. And as your PI goes up, thinking back to the French study, right? As your PI goes up, you're adding upper arc of lordosis. You add upper arc of lordosis that moves the so-called apex of your lumbar lordosis rostral. That upper arc of lordosis creates more lower thoracic kyphosis, which gets us to here. I'm running out of time. So what we did, I wanted to know how normal people stand, and Jeff Hills measured everything. And these are 2 examples from means PI of 80, PI of 30, and we measured the pelvic angles, which are centroid to the femoral head to the middle of the sacrum, or the vertebral body tilts, which are the same, centroid to the femoral head to the vertical line. What you will see is that the tilts are actually the same. And that's why we tried to term tilts a measure of balance. Your vertebral bodies relative to a vertical off the femoral head are all in the same place, irrespective of your PI. It's just how they get there. And that's where we came up with this, is measuring these knots, right? It's a spine shape, it's a spline, and the vertebral pelvic angles now tell you the shape of the spine in relation to where the hips are. And if we can know what a normal vertebral pelvic angle distribution is, then we can put you back to normal. I think one of the things important from the last slide, I don't want to skip too much, but I don't want to go over. All right, never mind. If we do L1 pelvic angle by pelvic incidence, the R squared is 0.6 for a single variable in a biological system. That's really high. And then I think whatever your sort of belief is, the great creator, God, whatever, nothing, whoever did it knew, right, that we were going to try and fuse them, so gave us pretty generous error bars of 4 degrees on each side, where you will capture 80% of the population. where the number is half of pi minus, it's 21. Dan Rue always told me use multiples of 5, so I go half of pi minus 20. So we do this, right? And this gives us an idea of where L1 needs to be by the centroid. Then we look at the tilts, and you will see that T4 and L1 tend to be in the same place. That is the only reason why we chose T4. There's nothing special about T4 other than that's what the data told us. So the vertebral pelvic angles describe in a continuous manner the shape of the spine in relation to the pelvis, to relation to the position of the hips. It also, one of the things we found as we looked, trying to prove to the Roussely camp that the VPA are a continuous measure of the Roussely classification system, what we found is that as your PI goes up, first of all, the LPAs, look at that, those are the distributions for 4s, 3s, 2s, 1s are uncommon. Any evidence that this is correct. So this is ISSG data appropriately analyzed from a group that was not trying, I don't think that they weren't aiming for L1PA, we just said, this is what we have, let's look and see. And so this deviation from normal, right, 0, so 2 degrees off was the lowest for probability of failure. Now notice, especially the young guys, it's still 10% risk of a mechanical failure, even if you nail it. Then these different colored bars are the variation between your thoracic alignment and your lumbar spine. So if you nail them, but you leave them forward, you are at a pretty high risk for a proximal failure. If you nail them in both planes, that's how you get to the lowest risk. We also wanted to see, like, suppose they don't fail. Is it still bad to be malaligned? And sure enough, it looks like even if you don't have a mechanical failure, your patient-reported outcome measures are affected by this. So and then here's top quote. This is from Dr. Lenke. Kelly, this is great, but you're being ridiculous. We want categories and we want equations. So if you want to put it together, target lordosis is about 60% of pelvic incidence plus 30. That gives you a ballpark number that you're going to need to get. And I look at the CT scan. Get them supine, see what it is on the CT scan. Then you figure out where you got to get more. Target L1PA is half of PI minus 20. That is going to tell you where you need to put your more and help you get to L1 in the right place. T4 tends to be within 4 degrees of the L1PA, but it does vary with pelvic incidence. So if you have a very low PI, your T4 tends to be more ventral, as opposed to a high PI, their T4 tends to be more dorsal. And those are the data that help you build a plan